Well, hi everyone. So, welcome to day 3 and case 3 of our series Image of the Day and MCQ of the Day. I suppose everyone is very well versed with this series that is being conducted on Facebook, on Telegram, YouTube, Instagram. So, basically, for all the tech savvy social media, people. So, this is available on any platform that you are comfortable with so that I can reach out to you with this series and you benefit from it basically. So it's a very short series. Today is day 3 in which we are practically going to discuss one image and one MCQ, but today I have tried to bring out the same organ in terms of the image and the MCQ. It's a very short discussion, so without a further delay, let's begin with it. This was the image that was provided to you and you had to give me it was a spotter image. You had to give me what particular finding you're seeing out here. So, well, yes, maybe I can show it to you separately. First and foremost, the answer to the question is Enterobius vermicularis. I hope everyone remembers Enterobius vermicularis. The other name is the pinworm. And yes, all of you have very well guessed which particular organ am I going to talk about today. We are dealing with the appendix. Yes. Okay, so let me just show you this picture and show you different types of images you can get pertinent to Enterobius vermicularis when you're talking about histopath, and then maybe I can show you the eggs of microbiology also. So number one image that you have, the one that was given to you, was this, right? So if I dissect it, the key of identifying these is, look at this. When you see this Enterobius, do you see these two lateral cuticular alae? Yes, and that's the key of identifying pinworm or Enterobius vermicularis. Let me tell you this one, and if I show you over here, so these are also Enterobius. So you can see that cuticular alae, that projection, that pointed projection. So it will have two lateral cuticular alae. Please remember, it is going to have two lateral cuticular alae, and that is how we pick up the pinworm or Enterobius vermicularis. Let me get you familiar with some more images. Look at this one. This is again taken up from the lumen of the appendix. Here you can see the appendix also. Can you see the lining of the appendix out here? Can you see the goblet cells as well? Can you see the blue cells, which is the dense lymphoid aggregate? I hope everyone remembers the basic histology from first year, that appendix has a dense lymphoid aggregate. So you can see that as well. And in the lumen, you can see this particular organism. And do you notice very, very carefully, again, the two lateral cuticular alae are visible. So yes, that's your striking point, which is going to help you. Now, this usually comes across as an incidental finding. So many a times it can come to you as a spotter, and very occasionally it is responsible for causing appendicitis or acute appendicitis, as which you say. So appendicitis actually comes second most. It is not very common. Usually it presents with an incidental finding, and all of you know the classical feature with Enterobius, that is pruritus. Perianal itching or pruritus is definitely there. Let me show you some more pictures. Do you remember from microbiology the classical eggs and what is the technique we apply or employ for these? Do you remember the cellulose tape method or tape preparation that we use to get the Enterobius eggs? And if I zoom into one of those eggs, I hope you remember that these eggs, as you see out here, these are classically defined as the Plano convex eggs. These are the Plano convex eggs, and inside, so they look like this. Okay, they'll be Plano convex, and inside them, do you see this line like structure that you have? Yes, this is the tadpole larva. This is the tadpole larva. So let me show you some different staining methodologies and the same egg, how it looks under different stains. Let us see that. So see, this is a picture that I came across. If you see the same Enterobius plano convex egg under an ultraviolet light, this is the kind of image that you're going to see. So yes, probably something we've not seen earlier. So just trying to show you that, if you know your basic well, no matter how the image is twisted and put in front of you, you will be able to catch hold of it. So it's the same egg under ultraviolet ultraviolet light. The same egg if stained with a pap stain. See again the Plano convex egg, and you can see that tadpole larva in between. So these are all the same staining methodologies. So well guys, that was your image of the day. If you want to do a quick recap, this was the Enterobius Vermiculitis, which you are identifying with the help of two cuticular alae. That's the worm. If you want to see the cuticular alae again, here it is. Further, this is usually an incidental finding, rarely leading to appendicitis. These are the eggs which you get, the Plano convex eggs with the tadpole larva, same as you see on ultraviolet light and same as you see on a pap smear or a pap stain. Now having done that, you know what we are moving on to next. That was the image of the day. So now let's move on to MCQ of the day. So I just posted this a while ago and let's see if you can attempt it. So let's begin with MCQ of the day and let's read it together. So we have a 17-year-old girl who presents with right lower quadrant abdominal pain. The pain is classically defined as crampy and imaging is showing an enlarged appendix. So obviously an appendicectomy is done, and the histological features as well as the slide is everything is mentioned in the question. So they've told you that there's a dense neutrophilic inflammatory infiltrate seen in which layer of the appendix? In the serosa. And they've very well shown you the image also. They've highlighted the neutrophilic inflammatory infiltrate in the serosa. They want you to tell the likely diagnosis. So perforation appendix, acute appendicitis, acute salpingitis, or inflammatory bowel disease. The answer to this question was acute salpingitis, which suddenly sounds a little random amongst the history, but I'll tell you how we actually diagnose acute appendicitis. So you'll say that appendix was removed and appendix was enlarged, appendix was removed, crampy lower abdominal pain is there. So why not acute appendicitis? Because the entire story changes here when I see the histopath. Let me show you these two pictures now. So let me tell you that for making the diagnosis of acute appendicitis, as a pathologist, when I get a biopsy of or when I get an appendicectomy specimen, when do I say acute appendicitis? I should see neutrophils. That is why, neutrophils, everyone remembers neutrophils are the cells of acute inflammation. But neutrophils should be seen in which layer? In the muscularis propria, or the muscle layer, not in any other layer. It's the muscle layer which should show. So I'll zoom into this image now. And can you appreciate these pinkish fibers, muscle fibers out here? Yes. I hope everyone can appreciate. And in between these pinkish fibers, can you appreciate these cells, those very tiny inflammatory cells that are present? Some of them, it's not very well discernible if they are neutros or anything else, but definitely some inflammatory cells are present. So coming back to our point, in which layer should you see the cells to call it acute appendicitis? In the muscle layer, in the muscularis. Whereas if you see inflammation in the serosa, this means it is inflammation surrounding the appendix. This means it is periappendicitis. Now this doesn't mean it is appendicitis. Periappendicitis means that some inflammation from the surrounding has extended onto the appendix. Some surrounding inflammation has extended onto the appendix. So for example, one of the very common causes in females is salpingitis. That is fallopian tube inflammation, and salpingitis can extend into the serosa. Can you see the serosa, the outer layer showing you all those dot-like inflammatory cells? So yes, that's periappendicitis. So now come back to the question. Very clearly the examiner has marked that the inflammation is in the serosa, has mentioned that the inflammation is in the serosa. So obviously it's not acute appendicitis. It's not even perforation appendix, because in perforation appendix, will you see a proper muscle layer like you see out here? Will you see a proper muscle layer? No, if it's perforated, the muscle layer would not be seen. So definitely the answer over here, you're actually seeing periappendicitis. So the answer over here is acute salpingitis. So that was the question or the MCQ of the day and the image of the day, both of which belonging to the appendix. I hope all of you benefited from it. And please keep revising. So we'll meet again tomorrow with another image and another MCQ. Take care.